Ladies and gentlemen, Nicole Recine.
Good morning. My name is Nicole Recine, and I am going to talk about how diabetes is mistreated in the healthcare system. So, a little background on me. I am a nurse. I became a certified diabetes educator in 2015 with the intention of treating diabetics using a low-carb, high-fat approach. And I'm currently in school to become a primary care nurse practitioner. Just to give you some perspective, I started learning about low-carb, high-fat, ketogenic diets in the context of diabetes and insulin resistance and obesity during my time in nursing school when I read a book called Good Calories, Bad Calories by Gary Taubes. And from there I started learning more and more, but I've gone through the healthcare system from the very beginning, understanding this science and sort of seeing everything through this lens. And that's kind of shaped my perspective and what I want to tell you about today. So I'm going to start off telling you about the problem with how we view diabetes type 2 in healthcare. So, healthcare practitioners generally think of type 2 diabetes as a problem of too high blood sugar caused by pancreatic burnout, and that the problem is too little insulin. And don't get me wrong, high blood sugar is really bad for the body, but we think this is the main problem with type 2 diabetes. So all of our treatment and all of our focus is on getting that blood sugar normal by any means necessary, even if it's to the detriment of the rest of the body. And we do this by either giving exogenous insulin or oral glucose-lowering medications or a combination of both. Now, why is this a problem? It's a problem because we fail to recognize the root cause of type 2 diabetes, which is actually too much insulin in the blood. Insulin resistance, hyperinsulinemia. And I think it's really important for everyone to understand this at a very basic level. So I'm going to give you all kind of a insulin resistance 101, very simplified. So whenever we eat, our blood sugar goes up, and this is normal. But the body knows that too high blood sugar over a long period of time is very damaging. So it does everything in its power to keep that blood sugar within normal limits, roughly 60 to 100. Now, when your blood sugar goes up after a meal, your pancreas secretes insulin. And insulin is a hormone that helps to move that sugar from the bloodstream into the cells, either for storage or to be used as energy. And this is a much safer place for the sugar to be, not accumulating in the bloodstream. And your body does this really well. It keeps this balance of blood sugar going up after you eat and bringing it back down to within normal limits. However, on the standard American diet, people are eating carbohydrates in excessive amounts that the body has never seen before. Breakfast, lunch, dinner, snacks in between, and sugary beverages on top. So blood glucose is constantly being elevated. But the body can handle it. It starts overproducing insulin to compensate. Overproducing insulin, and it does this, and it keeps the blood sugar normal by overcompensating with hyperinsulinemia. Now, whenever the body is exposed to a stimulus over a long period of time, it starts to become tolerant and resistant to that stimulus, much like if you drink a lot of alcohol over a long period of time. You become tolerant to the effects of alcohol. You need more to get the same effect. Same thing with pain medications, chronic use of pain medication, the body becomes tolerant. You need more to get the same effect. Well, the same thing happens with chronic hyperinsulinemia. Your body starts to become tolerant to the effects of insulin, i.e. insulin resistance. Your body becomes tolerant, and then you need more insulin to get the same effect, to normalize the blood sugar. And guess what? The body does this too. It starts overproducing insulin, not only to compensate for the high carbohydrate diet, but now also to compensate for the fact that your body's becoming tolerant to insulin. And a guy named Dr. Kraft called this diabetes in situ. This phenomenon goes on for years to decades before type 2 diabetes ever manifests. Your body compensating with hyperinsulinemia in the presence of normal blood sugars. Why? Because your body's compensating. It wants to do everything it can to keep those blood sugars normal for as long as possible. As practitioners, we ignore this whole phenomenon. We never test insulin levels. We wait until the whole compensatory mechanism breaks down and blood glucose starts to accumulate in the blood. And then we diagnose type 2 diabetes. But if you were to test the insulin levels years to decades before, you would see hyperinsulinemia. But if you test the blood sugar, it's normal because the body's compensating. And Dr. Kraft sort of made a graphic representation of the different levels of hyperinsulinemia, different patterns of hyperinsulinemia that occur way before type 2 diabetes. And remember, in each of these patterns, the blood sugar is still normal, and we're missing the boat. It's not until pattern 5, the very end stage, when the wheels fall off the wagon, the body can't keep up anymore. The pancreas burns out. It can't keep overproducing this insulin forever, and then you have frank type 2 diabetes, and then the healthcare practitioners start to worry about it and take action. So what's the solution? Address the root cause, not more insulin, not focus on the blood sugar, lower insulin levels. And how do we do this? Carbohydrate restriction, a low-carb diet, a ketogenic diet. You eliminate the carbohydrates, the original stimulus. You stop blood sugar elevations. You lower insulin. You allow total body stores of sugar to lower, burn some of the stores off, improve insulin sensitivity over time, and normalize blood sugar and A1C. And you'll see that a lot of examples here at this conference of that happening in people's lives. So now I'm going to sort of walk you through what it's like to be a healthcare practitioner and what the information I'm exposed to at all the different levels that I've interacted with the healthcare system. Knowing and remembering the problem is not the blood sugar. The elevated blood sugar is an end symptom. The root cause of disease is insulin resistance and hyperinsulinemia. So keep that in mind. So I'm going to start with the ADA. What are they telling me? Anytime a healthcare practitioner wants to know anything about diabetes, we are directed to the ADA. They are considered gold standard. Whatever they say about diabetes goes. So I'm going to take you straight to some of the things they say on their website. First of all, they say that carbs affect blood glucose much more than any other food, much more than meat, much more than vegetables, much more than fat. They know this. They're not dumb. They know which foods raise blood sugar the most. And then they go on to give many examples of foods with carbohydrates. So intuitively, you would think that they would tell me I should limit those foods in my patients. Well, no, actually. They tell me that I should tell my patients to eat lots of carbohydrates consistently throughout the day, all day, every day, like it's their full-time job to eat carbohydrates. And the ADA likes to claim that they don't recommend or endorse any specific plan of eating or any specific diets. However, they like to give general guidelines of very specific diets, very specifically high carbohydrate diets, that are going to make my patients a lot worse. This is straight from their website again. As a general guideline, they recommend 45 to 60 grams of carbohydrates at each meal and 15 to 20 grams between meals, that's snacks. Now we know on a ketogenic diet, we recommend less than 20 grams of carbohydrates per day. They want my patients eating 3 times that amount at each meal, like several times a day. And then the next slide is probably what makes me the most angry about the ADA, is straight from their website, is the biggest lie of all. They say that for most people, type 2 diabetes is a progressive disease, and that using insulin to get blood glucose to a healthy level is a good thing, not a bad one. Well, first of all, that's a lie. We know that on a low-carb, high-fat, ketogenic diet, disease progression stops and oftentimes reverses, and patients come off of medication. So that's a lie. Their solution, eat lots and lots and lots of carbohydrates all day long, have my patients compensate with medication and insulin, allow for hyperinsulinemia beyond what the body is capable of even on its own, like more insulin on top of already high insulin levels, and allow for disease progression, again, beyond what the body is capable of on its own. When you give a patient exogenous insulin, more insulin, you see their blood sugar may improve or normalize, but underlying disease continues to progress. Why? Because you're adding more insulin to what the root cause was, already high insulin levels. So you'll see blood sugars normalize or improve, but the patients still get retinopathy, they still get neuropathy, they still get end organ disease. Why? Because the underlying disease progress is still continuing. So actually using insulin to get blood sugars to a healthy level is actually a really bad thing. It's really harmful to the body. So now I'm going to talk to you about what I see in the hospital as a nurse, and how diabetics are treated if they go to the hospital for whatever reason, surgery, what have you. And this is a picture I took at my first job. That's my hand. This is a diabetic meal card, and I remember taking this picture because I was so appalled by what it was, and bringing this tray to this patient, this diabetic patient, thinking, I am literally giving this diabetic patient 100% carbohydrates, aside from the fake butter there. And it's totally legit on their plan, mostly because it's low fat and there's no meat, and we're counting the calories. It was literally like pancakes, white pancakes with sugar-free syrup, cornflakes, fat-free milk, just 100% carbohydrates. And when a patient goes into the hospital, next slide. There we go. They're usually put on this carb-consistent protocol, which is another plan put out by the ADA, where they get a specific amount of carbohydrates at each meal, and the nurse can then give a specific amount of insulin to cover those carbohydrates. And then they're placed on this sliding scale insulin regimen where the nurses go around and check the diabetic's blood sugar before the meal, before they get their tray, give their planned amount of insulin to cover the meal, plus more insulin to correct the high blood sugar from the last meal, which, as you can guess, was pretty high based on that tray I just showed you. And this is supposed to provide tight glucose control because it's so titrated and exact. Well, just FYI, it never works that way. Patients' blood sugars are all over the place in the hospital. And it sort of creates this thing where nurses are afraid not of high blood sugar in their diabetics, but of low blood sugar. Because when I inject insulin into my patient, fast-acting insulin, if they don't get their tray of carbohydrates within 15 to 20 minutes, 15 to 30 roughly, they're at risk for dropping, going hypoglycemic, either passing out or going into a hypoglycemic coma, because taking that much fast-acting insulin makes them dependent on eating carbohydrates. So nurses are always very careful and very afraid of the patients dropping low, so they're always pushing orange juice and giving IV dextrose just to be on the safe side, because the worst thing that could happen is my patient passes out from low blood sugar from insulin that I gave. Insulin is not a benign drug, it's actually very dangerous. Oops. So now I'm going to talk to you about Certified Diabetes Educator. I got this certification in 2015. I had to answer a lot of questions wrong in order to pass the certification exam. Nonetheless, what are we? We are basically foot soldiers for the ADA. We are healthcare professionals that are trained to teach patients, one-on-one usually, how to manage their diabetes using the ADA protocols. Now, the ADA loves to say that low-carb, high-fat, ketogenic diets are too restrictive and too difficult for patients, so they don't recommend it. It's not realistic. However, they have had to create certified diabetes educators to go out and teach patients how to live according to their protocols, how to inject insulin all day, how to store insulin, how to test their blood sugar, how to take all of the medications, what to do about side effects of these medications, how to store insulin, how to rotate injection sites. Because I think that sounds a lot more complex and difficult than simply giving up carbohydrates and following a delicious low-carb, high-fat diet. That's my opinion, may be different from the ADA. It is what it is. So certified diabetes educators learn about diet. And I'm just going to show you a couple of slides from the American Association of Diabetes Educators conference this year. I didn't go, but these are all posted online. This is what I learned as a certified diabetes educator. This is not inside information or anything. Next slide. Oh, there we go. So first of all, they claim that there is no clinical trials to support low-carb diets in prevention or treatment of diabetes, and that diabetes and overweight and obesity is mostly because people just eat too much of everything. It has nothing to do with carbohydrates, and that quality of carbohydrates matters more than quantity. So I'm not sure where they're looking and doing their research and literature review, but I see lots of trials coming out more and more every year showing that ketogenic diets and low-carb, high-fat diets outperform standard of care significantly, like blow it out of the water. And then they say that diabetics should just follow the same guidelines as the rest of America, the RDIs, the food guide pyramid, 45 to 65% of calories from carbohydrates, and that half of the grains that they eat should be whole grains. So as a certified diabetes educator, I can say as long as my patient has some whole grain brown rice or quinoa for dinner, the sweet roll at breakfast is totally cool, like offset bad with less bad. And then they go on to repeat the same lie that the ADA tells us, that type 2 diabetes is progressive, that most people with type 2 diabetes will need glucose-lowering medications eventually, insulin replacement, and that lifestyle intervention alone is not going to manage my patient's blood sugars levels. Now, we know that's not true. A low-carb, high-fat diet, ketogenic diet stops and reverses disease progression. But I would agree. On their lifestyle recommendations, on the ADA recommendations, yes, my patients are going to get worse, and my patients are going to need medication and eventually insulin. So now primary care. I told you guys I'm currently now in school to become a primary care nurse practitioner. We are the ones managing diabetics in this country. So what are we learning? And I'm going to show you exactly what I'm learning straight from my textbook. So this is really important, this part. Page 889, we learn the pathophysiology of type 2 diabetes is insulin resistance and hyperinsulinemia. This is a quote right from my book, Compensatory Hyperinsulinemia. Exactly what Dr. Kraft described, diabetes in situ. Exactly what I described at the beginning of this lecture. The root cause of diabetes is hyperinsulinemia manifesting years to decades before diabetes ever occurs. Just to be sure, I checked a medical textbook at my medical library at work. The med students are learning the same thing. It's all described right there. This is non-controversial. Pathophysiology of type 2 diabetes 101. This is not a hypothesis. This is not an alternative viewpoint. This is the pathophysiology of type 2 diabetes. Insulin resistance. Yet, so after we learn the pathophysiology, we then learn how to diagnose disease. So these are the diagnostic tests I am told to run as a primary care provider. A random glucose, a hemoglobin A1C, a fasting glucose, or a 2-hour oral glucose tolerance test. Now something's missing, the insulin. I am never told to test the insulin, a fasting insulin, a random insulin, definitely not an insulin assay like Dr. Kraft recommended. I am taught to ignore the problem that's happening years to decades before type 2 diabetes. We're taught to ignore it. As long as the patient's blood sugar is okay, they're good to go. You're fine. Keep doing what you're doing. Maybe lose some weight. That's it. And that's what I'm taught. And so you wonder why doctors never test insulin levels. It's because we're not taught to. We're not taught to care about insulin levels or insulin resistance or the significance behind how it's connected to type 2 diabetes. Okay, so fine. My patient's now diabetic. What do I do now? So diet and exercise, the first line treatment. Awesome. I don't put them on medications right away. I give them a chance. But I am told to give them the same advice back to the ADA guidelines, a low-fat, high-carbohydrate diet. My book actually recommends 60 to 70% of calories from carbohydrates, like super high carbs, super low fat. That's absolutely ridiculous in my opinion. And then I give my patients a 3-month trial period to go out and try to improve themselves with diet and exercise alone. And a lot of patients get scared of their diagnosis, and they really do try, and they'll do everything they think they're supposed to do. They'll decrease portion sizes, increase their whole grains, switch from white rice to brown rice, cut out red meat, buy everything low fat, join a gym, etc. Like they're really trying. And then they come back in 3 months, they're not any better. Maybe a little bit, definitely not normal. Sometimes worse. And what do I say as a practitioner? It's the patient's fault. They're non-compliant. They're not trying hard enough. They aren't exercising. They're just eating too much. They're lazy. Whatever blame we want to place on the patient. It's not the patient's fault. It's my fault. It's my fault because I'm giving them advice that's setting them up for failure. It's bad advice. And I'm not saying it's primary care provider's fault, but it's the system within which we find ourselves. The advice I'm being told at every step of the process of what I'm supposed to tell my patients and what to expect. So, okay, well now my patient's not any better, it's time to start therapy. How do I do that? Now, just an FYI, primary care providers have to diagnose and treat anything that walks into their office, including diabetes. So we're given a lot of quick guidelines and references that help us, once we diagnose a disease, to quickly start treatment. And in a lot of cases, it's really, these guidelines and algorithms are really, really helpful and effective. But I've noticed for diseases of lifestyle, such as diabetes or high blood pressure, these are just basically cookbook algorithms and methods to start my patient on medication and increase them to needing more and more medication, never addressing the underlying lifestyle cause. And so here's one such algorithm for diabetes. And this is exactly what they look like. This one is from the American Association of Clinical Endocrinologists. And there's many out there, but this is an example. So generally, anybody can look at this and see. You start your patient where their hemoglobin A1C falls generally on one drug, usually metformin. Then as they get worse, because they're still eating carbohydrates, you progress them onto 2 drugs as their hemoglobin A1C goes up, then to 3 drugs. And then just like the ADA predicted would happen, now they're on insulin therapy. Why? Because they're still eating carbohydrates this whole time, never addressing the root cause, never addressing the insulin resistance, never lowering the insulin level, never improving insulin sensitivity. But this is what I am told to expect, this is what the patient is told to expect, and this is all considered natural disease progression because we're told time and time again that diabetes is a progressive disease and there's nothing you can do about it, and this is all necessary. Well, it's not necessary. On a low-carb, high-fat diet, most of the time all of this goes away, and patients come off of medication. So, my summary recommendations: carbohydrate restriction should be the first-line approach to diabetes management. There's an article entitled Just This. Many of the co-authors are here in the audience. It's one of my favorite articles. I would suggest everybody read it. We need to start educating students and current providers on the significance of hyperinsulinemia and insulin resistance as it relates to type 2 diabetes, not as a separate phenomenon. We need to stop misleading patients. Stop saying that low carb, high fat is too difficult and therefore it shouldn't be an option. We need to give them all of the information, including the benefits of ketogenic and low carb, high fat diets in treating diabetes. Then, if they decide they don't want anything to do with it, they want to continue eating their carbohydrates and take medications and take insulin, that's fine. But then at least at that point, it's informed decision making. Right now, they're being lied to, and it's unethical. they're not being given all of the treatment options. And then I recommend carb sugar cessation as a requirement for every type 2 diabetic patient in the primary care setting at every visit. Much like when a smoker comes into my office, I am required to provide smoking cessation advice at every office visit. If we did this for every type 2 diabetic, it would really get the message across that carbs and sugar are the problem. And even if they're not ready at the first visit, if they keep hearing that same advice, they may be ready to hear it at the 10th or 15th visit. You never know. And that's all I have. Thank you guys so much. Thank you, Brian and Jimmy, for putting on KetoCon. I have 5 minutes for questions.
Hi, my name's Wendy, and I'm really happy with your presentation. My stepdad passed away last year, exactly the progression that you were describing. He was diagnosed with type 2 when I was a little girl, and by the time he died, he had heart complications, and he had, an insulin pump installed and everything. So I guess my question is, what progress do you see with the ADA? Are they going to change this? Because I feel like it causes so much heartache and anger that, it feels hopeless.
To be honest, it causes me a lot of anger as well, and I don't see the ADA changing just because there's so many forces that drive the ADA as far as pharmaceutical incentives. And I don't see that changing. I would encourage more people who are low carb, high fat, and have a ketogenic approach, not to shy away from the medical system, but to go into the medical system and get the degrees and sort of take it from the inside rather than shying away and not getting a medical education or a nursing degree or becoming a dietitian.
Thank you. Keep doing what you're doing, please.
Thank you.
How are you going to function in the current system and maintain your certification? To what extent are you going to have to compromise your knowledge and your values in order to function?
Well, what's the question?
I'm just saying, knowing what you know and knowing how counter it is to your certification, what you had to say for your certification and get certified and be a practitioner, how are you going to be true to what you know and your values in the face of a system that's contrary to what you know and your values? To what extent are you going to have to compromise?
I don't compromise. I mean, in the hospital, yes, I have to go along with what the hospital protocols call for, but as far as my independent practice as a certified diabetes educator and as a nurse practitioner, I refuse to compromise my knowledge and my values.
Hello, thank you very much for your presentation. I am a nurse for 40 years and I'm appalled at some of the education that we have delivered to our patients. We have a lot of people here that are lay people, and if we're going to start asking for insulin levels, what's the best way for the regular non-practitioner to talk to the doctor to request it so the doctor understands that they know what they're asking for?
Yeah.
Because you and I will say it one way, but how, I just thought that might be helpful.
I always tell my patients to ask their doctor for a fasting insulin at the very least, even if the doctor doesn't understand how to interpret it. If the doctor refuses, go online and order it yourself. You can do it through direct-to-consumer labs now, and it's pretty cheap.
I'm on a ketogenic diet, and my blood sugar management is all right, but in the morning, sometimes I wake up with very high blood sugar, fasting blood sugar in the 130s, 40s.
Mm-hmm.
On good days, it's in the 110s. Do you have any advice?
It's hard to know advise without knowing your full story and your diet and everything, all the details. I generally tell my patients not to chase blood sugars and just continue to test and notice your trends, and continue to follow a low-carb, high-fat diet. And then, there's a lot of nuance that goes into it. It's hard for me to advise just knowing that little piece of information.
Are there any tests I can ask my doctor to run?
A fasting insulin for sure.
Okay, thanks.
I know.
That's it. No more questions. I'm done. Thank you, guys.